So no disclosures relevant to this topic. So as Joe said, I'm going to talk about prosthetic options for femoral neck fractures, which I used to say displaced femoral neck fractures. As Joe just said, there's even, I think, an increase in recognition that they have a role in the valgus impacted femoral neck fractures. But when you're talking about prosthetic options, really you're looking at a standard hemiarthroplasty, which could be either modular or unipolar, or a total hip arthroplasty. And so I think in 10 minutes, I'm going to try to address these questions. When is a total hip appropriate? Maybe a little bit about how you should be doing a total hip. If you're going to do a hemiarthroplasty, should it be a or should it be, a unipolar or a bipolar? For either arthroplasty, how are you going to fix the stem? That cement versus uncemented controversy is still out there. And any other technical-related choices that matter, I think we'll briefly touch on. So total hip replacement has been performed in femoral neck fractures for decades. The first large case series was reported in 1980 from the Mayo Clinic. There are now dozens of randomized clinical trials that tend to show superior outcome and longevity with total hips, but the most recent literature is swinging the pendulum back a little bit, which I'll talk about. But this is a paper from Franklin Sim and colleagues at the Mayo Clinic, over 100 patients. Even in those years, in the 1970s, were doing total hips in patients that had a high activity level. Obviously, those that had pre-existing arthritis, which were rare, but they also, and I think interestingly, looked at patients that were pretty frail and had advanced medical disease. And I think this is because they recognized the need to avoid potential reoperation and just do one surgery in these more complicated patients. So in 2024, total hip replacement is definitely an appropriate option, but I think there's still the question about which patients are ideal for a total hip. This is a paper that I think is awesome. It's an old paper. This is a prospective randomized study that was actually done in the 1980s, which was pretty ahead of its time. They had 271 patients. They randomized them into the three groups that you see, fixation or the various arthroplasties. And Skinner reported the one-year outcome back in 1989. Mortality was equivalent. A quarter of the fixated patients had been converted to total hips within the first year. Significantly more were having pain. Interestingly, even a quarter roughly of the hemiarthroplasty patients were having pain, and the total hip patients were doing very well. Different authors followed up that same cohort of patients in 2000 and reported long-term 13-year results. And what was interesting was that both the internal fixation and the hemiarthroplasty patients deteriorated, and I suspect that's because neither operation fully restores hip biomechanics. And the total hip group, even in the longer-term follow-up, continued to do well. And there are multiple studies published since. This is just one from Scotland, where they really do very well-designed prospective randomized studies and tend to find the same thing. Whether you look at mortality, reoperations, complications, functional measures, economic outcomes, the total hips arthroplasties tended to be at the top. And so this study, 207 patients, they randomized 91 of them between fixation and hemiarthroplasty, no difference in outcomes. The functional scores favored arthroplasty. The best outcomes were with total hip arthroplasty. And surprisingly, when you look at the long-term economic cost of total hip, is actually most cost-effective as well, primarily because of the lack of any need for reoperation. American Academy of Orthopedic Surgeons has evidence-based guidelines on management of hip fractures. They rate to what the evidence states and then the strength of the evidence. So there's moderate evidence that's typically about the best we ever get. That means there's at least one study of moderate quality that supports these findings, but supporting a benefit to total hip arthroplasty in properly selected patients. So it doesn't really tell you who to operate on, but that if you select them correctly, the evidence supports a benefit. This is one of those papers that's, I think, swinging the pendulum back. So Martin Parker, those of you who study the hip fracture literature will recognize that name, writes many of the Cochrane database updates. This is 104 patients that were randomized to either cemented hemiarthroplasty or cemented total hip. All the patients were followed, so it was the same stem, essentially just a different fixation or different articulation. They found no difference in outcome between groups for residual pain, for function, for regaining independence, and there are actually more complications and reoperations in the total hip group in this particular study. And these are just some of their findings. So probably hard to see from where you are, but the top is pain scores. You can see they're almost identical over 5 years. Middle one is change in mobility score, and the bottom is mean change in social dependency score. So finding really very little differences between total hip and hemiarthroplasty in a well-designed study. So I think as you really look at the literature, it still isn't perfectly clear that there's a significant benefit to total hips. And in certain patients, there are going to be. The very, very active patient, for example, you will see these 80-year-olds who are still out playing 18 holes of golf several times a week, or bike riding or swimming or pickleball, I guess is the thing these days. But those patients are rare. Another interesting question is if a person needs a total hip, is who should do it? And should it be can a trauma surgeon or a general surgeon do it? Or should it be an arthroplasty surgeon? And there's a few studies that are looking at this. This is a paper from George Sadakevich, 150 total hips for displaced neck fractures, and looked at the outcomes that you see. And interestingly, the complications were higher when trauma surgeons did these surgeries than for arthroplasty surgeons. So major surgical complications, 20% versus 7%. There was better component positioning from the arthroplasty surgeons, and implant survivorship, importantly, higher at 1 year for the arthroplasty surgeons. So this is a subset of the health study, which Dr. Schmidt and others were involved with. This was over 1,400 patients enrolled in a randomized trial of hemiarthroplasty versus totals. They looked at surgeons training. This is sort of a secondary analysis, and they looked at unplanned procedures in 2 years and serious complications. And again, if you look at the arrows point to unplanned secondary procedures at the top, dislocation the second one, and prosthetic joint infection the third one, and all of those were more common, again, when trauma surgeons did the case rather than an arthroplasty surgeon. So that's just interesting information. And I think with the knowledge that you may not need to do a total hip for a lot of these patients, maybe that's, you can put those two things together. Maybe we should be doing could be doing a little bit more hemiarthroplasty without hurting our patients. So when you talk about hemiarthroplasty, I think the real controversy is bipolar versus unipolar. The rationale for the bipolar initially was that motion at the inner bearing protected acetabular erosion from a unipolar type of device. They're easily revisable to a total hip if that were to occur, but that's, you don't want to plan to fail. Active patients may have pain with a hemiarthroplasty, but I think there's some reports of osteolysis occurring in bipolars, and I've got one case I'll show you in just a second. The dislocation rate in hemiarthroplasty is still appreciable, and the clinical results do deteriorate with time. And this is this case that was presented to me as a likely infected or certainly loose total hip, but this is actually a disassembled bipolar. And you can see the osteolysis that had occurred there. When you look at the unipolar versus bipolar debate, the Cochrane database was recently updated, so 13 studies, nearly 1,500 participants, low certainty evidence of little to no difference. So that's kind of awkward English, but basically it means they can't really tell the difference looking at the studies. So adverse events, outcomes, everything is pretty much the same. This is another paper looking at long-term reoperation rates after hemiarthroplasty. Differences between unipolar and bipolar. This is from the Swedish Arthroplasty Register, published just last year. They used very sophisticated statistics, so they did propensity scoring for treatment with a bipolar. They matched patients so that they had a less than 10% difference. This is basically creating a randomized clinical trial out of a large database. And basically, the reoperation rate was the same. They looked at all patients and then those that survived more than 5 years. But there were more reoperations in the bipolar patients, and importantly, the rates for reoperations due to acetabular erosion were higher in the unipolar group rather than the bipolar group. So there may be some evidence that the bipolar concept actually does work a little bit. Talking about fixation, another controversial aspect. So cementing a stem takes more time, may not be needed with modern uncemented implants. Reports of death during cementing are really not so much of a thing anymore, but there is that concern. Certainly a cemented stem is a much more difficult revision should that become necessary. Again, this is the Cochrane review, 17 current studies updated in 2022, moderate evidence of a benefit to cemented hemiarthroplasty construct. The differences in quality of life are all over the map from small to large. The functional differences see about the same, but there is a difference in intraoperative fractures primarily when you're trying to do an uncemented implant. Again, there are Academy's guidelines, moderate evidence supporting the preferential use of cemented stems for patients having arthroplasty for a femoral neck fracture. What do? I do a lot of arthroplasty for arthritis, and I basically do the same fixation. So if I am treating this patient's left hip for arthritis, I wouldn't have any concern about doing an uncemented stem. So why would I do something different on the right hip with this neck, transcervical neck fracture? So in this case, I used an uncemented stem, but I would say I do more cemented stems in my arthroplasty population. I want to teach the residents how to cement. They don't get much exposure to that. And I think there is less likelihood if you're not as comfortable doing stems. I use the same stem I do in my primary arthroplasty practice, so I'm pretty comfortable with how it should feel. And it's worked for me, but if you don't do a lot of arthroplasty, cemented stem is probably safer. So to conclude, I think conventional total hips are appropriate in the very active and healthy elderly patient with a displaced neck fracture. I'm starting to use some dual mobility components that don't have time to get into that, but we can talk about it later if you want. I think the modular unipolars and bipolars are appropriate for most patients. If you're going to do these arthroplasties, use the implants and approaches you're familiar with, and then of course, as Joe alluded to, the medical care of these patients is very appropriate also. Thank you.